proud to be here as chair of the caucus, here with members of our caucus. All of them will be introduced shortly, and members of the legislature. This is a bipartisan, multicultural, multi-caucus, all the things that it should be in the PC world that we live in. I am so happy to have your presence and your attendance. For those of you who know me, you know that I have one perspective with respect to the challenges that confront this state, whether it be in areas of education, immigration, health care, whatever the public policy concerns that affect us. California is an extraordinary state. It's the 8th largest economy of the world. It has incredible richness. During the recent break, all of us members were able to go home to their districts and just appreciate what a great state this is. And during the fall, many of us are able to travel around the world and see what great standing and stature California has in the world. And yet it is with incredible challenges. And one of the tremendous challenges that's perplexing for us, but also for the nation, is the challenge of how, as the 8th largest economy of the world, or as a nation, as the richest and most powerful nation in the history of the world, how is it that so many millions of Americans, so many residents of California, do not have access to health care? How is it that the mere discussion of ensuring and providing accessibility to health care for Americans riles up, provokes such a response from Americans that people go to rallies to listen to the president armed with weapons, with guns? What is it that creates this incredible divide in our nation, that someone would want to go to a discussion on health care with a weapon? And yet those are the challenges that confront us. Those are really what is at stake, I say, for the quality and nature of our democracy. We must find ways to make sure that all people, particularly in the state of California, with its incredible changing demographics, to make sure that we can make sure that people are healthy. You can neither earn nor learn if you are not healthy. And that is part of the mission of this discussion this afternoon. I applaud Joe Cotto for his leadership in this area. I applaud my colleagues who have joined me this afternoon. And more importantly, I applaud all of you who are here in attendance. I applaud you for your leadership, for being steadfast in your commitment to providing health care for everyone who share that perspective, those of you who share my perspective, that health care is a fundamental human right. The challenges that confront us, I say to you, are not challenges of capacity. This is not a third world nation. This is the 8th largest economy of the world. 220 nations behind us marvel at the richness of California. This is a challenge of leadership. And today, by your mere presence, you are demonstrating that leadership, that vision, and that commitment. I want to begin to let you know what the agenda holds forth for you. Warren Furutani is chair of the API caucus. Sandre Swanson is chair of the Black Caucus. Dave Jones is here from the Assembly Health Committee, and Elaine Alquist, chair of the Senate Health Committee, will soon be joining us. I'm also happy to be joined by Mary Salas from San Diego. Who else is? Fiona Ma from San Francisco. Paul Fong from Cupertino. Is that the area that we're giving him credit for?
Santa Clara County.
Santa Clara County, there you go.
He runs Santa Clara County.
Yes. And Mary Hayashi, of course. So let's hear it for these members who have taken their time from their busy schedules to be here with us this afternoon. I'm going to shorten my remarks. The caucus is very active. We have, if you notice, you may have walked in across the hall into another meeting, somewhat like Assemblymember Anthony Portantino is walking in right now. And you will see that we have two well-attended, very important activities going on. And so I apologize, I will have to excuse myself to also participate in the meeting across the hall. but that is not a reflection of our commitment, nor mine, to the importance of this issue. And I say that with all respect for your presence and your attendance this afternoon. Warren, I'm going to hand this over to your very capable hands. I'm going to hand it over, actually, to my chairman, my leader, the Latino Legislative Caucus, and a great leader for our entire state, Joe Cotto.
All right, thank you. Thank you. How about a big round of applause for Senator Cedillo? Gil Cedillo. It's going to be my function to keep the agenda moving. We're going to begin next to hear a few words from one of our assembly members who has devoted a lifetime to the area of health care. She helped organize an Asian Health Alliance. She's been involved at the national level, and she's been a champion for us here in the legislature in the area of health care. To bring a few words of greetings, the Honorable Mary Hayashi. Mary, please.
Thank you. Thank you, Mr. Cotto, and Senator Cedillo, for all your leadership. I am just very honored to be up here with my colleagues, as well as the presenters. I recognize many of you whom I have worked over the years, and so it's great to have you back here in the Capitol. I also want to recognize Mr. Joe Cotto. I have participated in I don't know how many health disparities conferences and panels over the years due to Mr. Cotto's commitment to highlighting this issue and keeping it alive, and traveled with Mr. Cotto throughout the state talking about the importance of closing this gap and eliminating health disparities in California. So thank you also, Mr. Cotto. Mr. Swanson, I believe, is representing the African American Caucus today, and look forward to working with you. Mr. Frutani was just elected as the new chair of the API Legislative Caucus, and I was also elected as the vice chair of the API Legislative Caucus. So we look forward to working together to highlight Asian American health disparities issues as well, and also joined by our esteemed Health Committee Chair Dave Jones. And I've been serving on the Health Committee for the past 2.5 years, so it's been a real pleasure to work with you, Dave. I just want to say very briefly, because I know we're going to hear from the experts and other members who are here. Before coming to the legislature, as some of you know, I served as the campaign director for the American Public Health Association when they had partnership with the Surgeon General. This was under Bill Clinton's administration. President Clinton and Surgeon General David Satcher called for campaign to eliminate ethnic health disparities in the United States. And I was very honored to serve as a director of that project at the national level. I worked with you, many of you in this room, for a number of years to address this issue. We have done a lot over the years, and I think that we have done incredible amount of public awareness, and we've been able to bring attention to this issue. And the challenge now is, I believe, following through and implementing all of the great reports that we've done, all the surveys, all the action plans that we've created. And so I think this forum, once again, serves as a great vehicle for us to implement some of the things that we've been talking about for a long time. And so with that, I want to hand this back over to you, Mr. Cotto. I'm very committed to this issue, working to reducing and eliminating health disparities that exist in the United States for people of color is one of my personal goals, and look forward to the dialogue today. So thank you very much.
Thank you. Big round of applause for Mary Hayashi. Thank you, Mary, for your comments. Let's go over now to Warren Furatami, who as the new chair of the Asian American Caucus is going to be working with all of us in addressing this issue. Warren, please, a few words from you.
Thank you very much, Joe. Ladies and gentlemen, this could not be a more timely discussion relative to not only the state of California, but what's going on in the nation as a whole. The issues that we're talking about really speak to access. They speak to really a version of the civil rights movement that goes beyond the triumphant integrations of schools and lunch counters and drinking fountains. We're talking about access to health care is what we're talking about. We're talking about access to quality water. We're talking about access to the right kind of energy and green jobs. That's what this is all about. That's the context. One of our other members, Mike Ng, is going to be on a panel later this afternoon talking about health disparities, a project he's been working on, a white paper relative to the API community, and I'm sure that will share a lot of information with all of you. So thank you very much, Joe, for having us here. As was said earlier, Mr. Swanson is chairing a very important hearing right across the hall, so we're going to be bouncing back and forth as we listen to the testimony today. Thank you, Joe.
Thank you very much, Warren, for it. Tommy, now let me call on the chair of the African American Caucus, a longtime friend of Joe Cotto and a champion for not just Oakland and Alameda County, but now doing some great work as chair of the former chair of the Labor Committee and just a close personal friend. Big round of applause for Sandre Swanson. Please, Sandre.
Thank you. Thank you, Assemblymember Cotto, and thank you for your chairmanship of the Legislative Task Force on Obesity and Diabetes, and for pushing this issue. My hat's off to you for the distinguished panel that you have here today. I notice you have Dr. Mark Smith here. He's forgotten more than I can ever remember about health care, so you have experts that are willing to help shed some light on a very, very important subject. I will tell you that this could not be a more important time for us to have this discussion, as California needs to play a leading role in this historic moment. I've been in public service for more than 30 years, and I will tell you there's only a few times in our history when we have an opportunity to address the question of health care, and this is one that is full of opportunity, with the President and the Congress focusing on this question, and the state of California with all the creative ideals that we have. I will tell you that it affects us in all walks of life. As we know, it's the leading cause of bankruptcy for many California families and families throughout the nation. There are health disparities, most certainly, that we must address. Growing numbers of African American and Latino families are being exposed to HIV and AIDS. All of us have our friends or personal stories about how it's affected each of us. I lost a younger brother to HIV and AIDS, and who would be alive today if he had access to medicines that are now readily available. But this is an environment where the state has cut funding for HIV and AIDS services, and so how many lives will be affected or lost by that? We can't lose sight of our responsibility. Health care should be a right and not a privilege, and it shouldn't be sold like a loaf of bread. And so we have to come together as a family and figure out how to address these questions in a way that speaks to our humanity as a society, and how and also it also makes great financial sense for us to get a handle on controlling and making sure that our healthcare system is more efficient. And so I joined with Chairman Cotto, and my entire caucus joins in this effort as we go forward. We're planning a delegation of the Assembly back to Washington, D.C. in a couple of weeks to meet with members of Congress and the Obama administration, and health care is one of the agenda items. And so this forum is very timely, and I look forward to the testimony and all the contributions that are made today by your fine panelists.
Thank you very much, Chairman Swanson, for those remarks. Let me now introduce the distinguished chair of the Health Committee of the State Assembly, doing a wonderful job leading the Health Committee and addressing the issues facing California. A big round of applause for the chair of the Health Committee, Assemblymember Dave Jones. Please, round of applause. Dave Jones.
Thank you. Thank you, Chairman Cotto, and I want to thank my colleagues and the distinguished panelists from whom we're going to hear in a moment about what is truly one of the most pressing issues facing California and the United States of America, and that is disparities in health care, not only the incidence of illness, disease, sickness, but also disparities in access to and receipt of quality care. And there are at least two significant dimensions across which this occurs. One is income, and the other is race and ethnicity. On income, we're involved right now at the national level in what is probably one of the most important debates of this generation, a debate that has been going on for some time, a debate that recently passed Senator Ted Kennedy devoted his life to addressing, and that is how do we make sure that we provide quality, affordable health care to all of the people in the United States of America. And my own personal view is the best way of doing that is with universal single-payer health care. And that is the reform to which we must build. But as you all know, at the national level, the conversation is focusing on a program not dissimilar from what we here in California debated just a short 2 years ago. To me, it's absolutely essential that at the very least we have a strong, robust public plan as a part of that national program, without which I fear we won't have universal, affordable access to health care. And the second dimension, and one on which Chairman Cotto has led so ably, as have my other colleagues, is the question of disparities with regard to ethnicity and race. And the simple truth here is in California, African Americans, Native Americans, Asian Pacific Islanders, and Latinos all suffer disproportionately higher incidences of chronic illness and disease than do whites. Just to pick one leading indicator, cardiovascular disease, for example, has a much higher prevalence amongst Latinos. It is a prevalence rate as high as 23% of all deaths. In addition, adult African Americans and Latinos have approximately twice the risk as whites of developing diabetes. And you go on and on and on. HIV/AIDS, infant mortality, cancer. We find these disparities, and they are simply unacceptable. For that reason, I introduced ACR 29 this year, directing the California Health and Human Services Agency to, across its member departments, focus on ethnic and racial disparities in health. And for that reason, I'm very cheered by Chairman Cotto's leadership and the leadership of all my colleagues here and the participation of these panelists and all of you who are in the audience today, taking a moment both to chronicle the problem but also to identify what we can do to solve it. Thank you very, very much for your leadership and participation. Chairman Cotto, thank you again for your leadership in this important area.
Thank you very much. Dave Jones, Chair of the Assembly Health Committee. We're going to hear from just one more Assembly member, and each of the other members that are up here will play a little role during the course of the agenda. But I know that Mary Salas has to leave for another meeting, so we wanted her to say a few words. And then we're going to ask Hector de la Torre, Assemblymember de la Torre, to introduce our first presenter. All right? So could we hear a few words from you, Mary Salas,
yes,
please?
Thank you very much, Chair Cotto. And I consider it a privilege to spend some time here with this distinguished panel, and I thank you for convening this. As you know, I am a member of the Health Care Committee, and you know, this is an issue that is very important to all Californians. And one of the things that happens in my district, which is one of the poorest areas of Southern California, is that there are so many people that are uninsured and are unable to go to the doctor to take care of simple problems that turn into large problems. And all of us here, I'm sure, do as I do. And I conduct at least 2 yearly health fairs in my district. And by far, those health fairs draw the largest number of people. And it's a very gratifying thing to be able to put on a health care clinic and to get all kinds of different organizations together to provide some level of assistance to the community for those days that we have the health care. And, you know, the types of people that come to those health fairs are just everyday, ordinary people that are working hard, that are worrying about their families. I've had situations where a young father came to me in tears. He had just lost his job and was wondering how he was going to provide the the family with the health care insurance that they needed, that he lost as a result of losing his job. And yet, the COBRA payments that he would have to pay were way beyond the family's budget. Those are the kinds of situations that face our families. There was another situation where a woman came to me and asked me to feel a lump in her breast that she could actually feel. And she was terrified, and yet, she was having to make decisions of whether or not she would go to the doctor because her family's finances were so tough that it was a choice between the family's food and rent for that month or her going to a doctor to find out what the problem was. And this is very common across the United States. So this is something that we have to get a handle on. As members have said here before, that healthcare is healthcare for all. Being able to access medical assistance should be a right, not a privilege of income or resources. And so today, thank you so much for being here, that we have this serious discussion about how we're going to fill this void, how we're going to meet that gap, and making sure that all our California community citizens have the right to thrive. Thank you.
Thank you very much, Assemblymember Salas. Now, as has already been indicated, we have an excellent panel of experts who are going to address us today. To do that, to introduce our first presenter, we're going to call on the chairman of the Committee on Accountability and Efficiency in Government, former chair of the Rules Committee, Hector de la Torre. Please, Hector.
Thank you, Mr. Chair. I appreciate the opportunity to be here, and I appreciate your leadership in organizing everybody, bringing everybody together to have this conversation. It's my honor to introduce Mark Smith. Dr. Smith is the president and CEO of California Healthcare Foundation. The foundation is an independent philanthropy with assets of $800 million, headquartered in Oakland, California. The foundation is dedicated to improving the health of the people of California through 3 program areas, 2 of which are directly connected to our topic today, the healthcare disparities in minority communities. First is innovations for the underserved. That's clearly us. Better chronic disease care. Again, that's us. And the third one is broader, and I'm sure somewhere in there we fit in, market and policy monitor. Dr. Smith is a board-certified internist. He is a member of the clinical faculty at UC San Francisco and an attending physician at the Positive Health Program for AIDS Care at San Francisco General Hospital. Prior to joining the foundation, Dr. Smith was executive vice director of the AIDS Services and assistant professor of AIDS Services and assistant professor of medicine and health policy and management at Johns Hopkins University, which is nationally recognized for their health policy and medical work. Dr. Smith received his BA from Harvard, MD from the School of Medicine at University of North Carolina, Chapel Hill, so he's a Tar Heel, and an MBA with a concentration in healthcare administration from Wharton. He's really covered his bases on the East Coast. We're proud to have him here on the West Coast, Dr. Smith.
Thank you, and good afternoon. It's a pleasure and honor to be here, and I think I know most of you. I'm going to be uncharacteristically brief today, in part because you have people who are engaged in the important work of outreach and patient advocacy. Además, voy a hacer mi discurso corto en inglés, porque mi español es tan malo y además tenemos mucha gente aquí que tiene una disabilidad lingüística que hablan únicamente en inglés, entonces lo siento mucho. My role here, I think, is in part to frame the issue that you have before you. As you've heard, our foundation does lots of work in looking at the way health care is delivered, how it's financed, how it's organized and managed in California. And part of our work around chronic disease has been the process of helping to give voice to people themselves in talking about their circumstances. So today we are releasing 3 new CHCF-funded reports about how Californians manage their chronic conditions. And while our reports are separate from the work that you'll hear from these frontline experts, hopefully they'll help frame some of how you can think about the policy responses that are possible for legislators and administrators to make in the face of these problems. I want to highlight just a couple of numbers for you. First of all, we found disparities for Latino patients and low-income patients with chronic conditions. Among Latino patients, 46% of them with chronic conditions, as opposed to 25% of white non-Hispanic Californians, have postponed health care due to the cost of that care, so nearly twice as many. Nearly 2/3 of Latino patients surveyed said they wish their doctor had more time to talk to them. And as a practicing physician, I always wish I had more time to talk to my patients. 25% of Latinos with chronic conditions say they only occasionally get the support they need to improve their health and manage their problems. And so when you hear from some of my colleagues from patient advocacy groups, that's often the work in which they are engaged. As someone who's had lots of breast cancer in the women in my life and my family, I can tell you that this is an extremely important task, not often well carried out by the formal medical care system. And people are constantly looking for ways in which to understand their disease, understand how to manage all the problems that go along with their disease. I do want to highlight a couple of facts that come from the report, and I won't go through the statistics, but I ask you to think about these issues as you hear my colleagues talk. First of all, insurance coverage is not the same as good health care. No one is more involved, no one is more supportive of our efforts in the state and the country to secure coverage, adequate, decent coverage for everyone, commensurate with what we ought to do in a rich country, which we are. But many of the problems that were reported by the patients in our survey were reported by patients who have insurance and who have doctors with whom they don't have enough time or from whom they don't get enough support. So while it's important to struggle for broadening insurance coverage, we need to also think about the other things that go along with improving people's health and managing their problems. Second, treatment is not the same as prevention. So I'm a physician. I take care of people with HIV. My colleagues take care of conditions like diabetes and congestive heart failure and arthritis. But many of the things that we need in our society, particularly for low-income people, to prevent these conditions are not, frankly, within the purview of the healthcare system or the health department. People's access to fresh fruits and vegetables, people's access to safe and locally relevant places for them to exercise, the ability of kids to have physical activity in their schools, no doctor can prescribe that. And so this is a multivariate problem, and while it's important for us to improve our access to insurance and our access to treatment, it's also important to recognize that both in financial terms and in human terms, many of the problems that you see described by the patients in our surveys and the problems that you'll hear my colleagues here talk about are actually preventable problems, problems that we can't afford to fix once they're developed, that we'll need to figure out how to prevent before they develop. And lastly, I'd like to suggest that one of the most important things we've found in talking with patients is their need for support. The fact is that while there continues to be a digital divide, black people, Latino people, Asian Pacific Islander people have access to the internet increasingly. They have access to other forms of support. And we need to think about how we can engage the activities, the energy, the enthusiasm of community-based organizations, of activists and volunteers like some of the people you hear from today, to support and augment the formal, paid, insured medical care system to prevent people's diseases and help them manage them when they get them. So with that, I'll be quiet. Thank you again for your leadership, Chairman Cotto, and for the Tri-Caucus in convening this hearing, and turn the podium back over to you.
Thank you very, very much. Our next presenter is Mariko Yamada in the audience yet? She was supposed to be here to introduce. Let me do it. Our next presenter is going to be Dr. Gabriel Halpern. He was inspired to be a doctor when he was 12 years old after watching Gilligan's Island. I'm sure he's going to tell us a little bit about that. He started his undergraduate study at Brooklyn College and graduated from St. John's University. He has attended podiatric school in San Francisco and completed residency training in Orange County. He enjoyed very much treating Hispanic patients. He found them appreciative, family-oriented, warm, and loving. He has has decided to open his office in East Los Angeles in 1980. At the time, he was the first doctor to open in East Los Angeles in 15 years. Please, a big round of applause to Dr. Gabriel Halpern. Please, Gabriel.
Thank you for giving me the opportunity of speaking today in this forum. I have to say my wife wrote that bio when I was given an award from the Latino Diabetes Association. So what it proves more than anything else is that my wife is proud of me. Going on with my own credentials, I'm medical director of the Olympia Wound Center in Los Angeles, as well as medical director of Paradigm Medical Management on the corporate level. We have 15 wound centers in California and outside California. But in California, we have acute care-based wound facilities associated with Los Angeles, Hawaiian Gardens, Bakersfield, San Francisco, and Fresno. And I think more to open in Modesto and Sacramento. Additionally, I'm a medical director of a transparent wound medical group. This is a medical group without walls. We take care and give service in 14 acute care hospitals, as well as the long-term acute care hospitals like Kindred, Vista, and Promise, and 90 skilled nursing facilities in Southern California. We run their wound management programs. I'm representing 12 physicians, including podiatrists, PAs, general surgeons, geriatrics, and internal medicine. But my love was my practice. I opened it in 1980. I was the founder, and I'm the medical director. We are an independent wound-based wound center. We're patient-centric, and we're ethnic-sensitive. Although I decided to open right in the middle of the barrio, we have patients from all over Southern California come to our office. We take care of Asian, we take care of Pacific Islanders, as well as Black, Latino, and others. Our expectations, and I think the secret of our success, is that the patients will not follow our instructions unless we fulfill their own needs. Being in East Los Angeles, especially in White Memorial Hospital, a Seventh-day Adventist missionary hospital, we created the mission of wound care, which was taken up by my whole family. My father-in-law died this morning, and his wish was that I should be here to speak on the behalf of all of my patients, as well as others that are suffering the afflictions of peripheral arterial disease, diabetes, and unnecessary amputations. He was part of that mission. Our specialties are wound management, limb preservation, limb salvage, which is like preservation, except we deal with much more serious issues trying to preserve a limb to walk on, and our healing rates are about 98%. Our amputation avoidance rates are 98%, which means that 98% of the time when a patient comes in that was destined for an amputation, we can cancel that surgery. What I'm talking today about is peripheral arterial disease, PAD. PAD affects 12 to 20% of Americans aged 65 and older. 12 million Americans are with PAD in the United States alone, and there's a 3 times greater risk with those with diabetes over the age of 50. In the Latino community and the Black community, it's even greater. I don't know the statistic. I think it's around 6 to 7 times percent. This is a picture of the buildup of the fatty substances in the wall of the artery that will stop the flow of the red blood cells as they proceed from the heart to the extremity. PAD prevalence in millions is 12 million. That's greater than congestive heart failure, stroke, and Alzheimer's combined. The only thing greater would be coronary heart disease and diabetes. More so, the 5-year mortality rate of PAD is 30%. greater than stroke, coronary artery disease, and breast cancer. The problem is PAD is painless, and the people who have it, most of them don't know that they do have it. The treatment for PAD in the old days was an amputation, as you could see from this etching. The treatment today for PAD is not much better, except the rooms are cleaner. The problem is, despite the advanced interventional techniques to restore the blood flow, amputation seems to be the most common therapy for critical leg ischemia, which is the worst part of PAD. PAD is a lack of perfusion. CLI is a heart attack of the leg or a stroke of the leg where the circulation is critically low. There are 200,000 amputations estimated in Europe and in the United States annually. The misconceptions and the lies are that a majority of diabetics will receive an amputation as a result of a lower extremity wound because it was absolutely necessary. The lie is absolutely. A major effort is always performed to avoid amputation on the diabetic, which is a misconception and an untruth. And the newest techniques are always used on every patient, which is another misconception. If a patient walks into an emergency room, based on the emergency room doctor and the doctor that takes over the patient's care, based on economics and based on the availability of the procedure in the emergency room, the patient most likely will be given the option of an amputation. Again, the buildup of fatty substances inside the wall of the artery. There's a percutaneous procedure now that can be done on virtually everybody. Anybody, regardless of age, regardless of medical condition. On the left is the percutaneous procedure, which is just a needle in the artery where a wire is inserted and a small device is inserted to remove the fatty substances. On the other hand, on the right, the surgical procedure is almost obsolete. It's the old-fashioned bypass. The results are pretty astounding. We could take a foot that's diabetic foot that is close to needing an amputation and restore it within 30 days. That's a 30-day resolution. This foot that had gangrene in the great toe and the discoloration is completely healed in 2 months. The problem is that there are sufficient resources to treat every diabetic wound, and there are sufficient resources to actually start prevention programs, but there's no knowledge of where to send the patient. There's minimal knowledge of that the resources even exist, and in many cases, there's just no wish to use those resources at all. The amputation impact on the third line, 18 to 24-month overall mortality is 40 to 60%. What I'm saying is that after an amputation, regardless of the medical condition of that patient, if the amputation was a non-traumatic amputation, 60% of the patients are dead in 2 years. They don't die of the amputation. They die of heart disease, stroke, and other cardiovascular problems. The problem is that the amputation causes abnormalities in the intima, inside the arteries. That presents itself as other cardiovascular problems elsewhere in the body. Less than 20% of the people who have amputations get an angiogram, and only 50% get an ultrasound. Most of these patients have limb salvage options, but the options, again, are not offered. The ADA stated that 85% of primary care doctors that treat diabetics, only 15% ask the patient to remove socks and shoes for their examinations. CLI, with critical limb ischemia, which is the worst of the PAD, of the patients with peripheral arterial disease, occurs in 1 to 3% of those with PAD, account for 150 amputations per year. The impact is that 1.5 to 2 million people in the U.S. and Europe suffer from CLI. The mortality rates, again, these are without amputations now. 1 year, 25%, 2 years, 31%, and in 3 years, 60% of those patients die. They do not die of the CLI in the leg. They die of the inflammatory changes in the rest of the cardiovascular system. They die of heart disease, and they die of stroke. The advocates of foot and leg amputations say that patients will die anyway. They're sick. And they say that the 60% mortality rate after 2 years would never change. However, they're wrong, because the prevention of that amputation through restoration of arterial flow actually brings the death rate back to a demographic normal for that area. The problem is that there's a pervasive attitude that amputations are inevitable, and because of lack of physician education regarding wound care and alternatives and a lack of public education, patients are denied access. In our practice, obesity, diabetes, hypertension, cardiovascular disease, and critical leg ischemia are the major issues. However, obesity seems to be endemic. A table for 4 should only be a table for 2. And there's a social disconnect that I see in my own practice over the last 30 years, regardless of the ethnicity of my patient. There's a tremendous social and educational disparity blocking inroads to control obesity. I don't know if the obesity is based on heritage, genetic propensities. In my case, a carbohydrate intolerance. My ancestors came from Eastern Europe. I weighed 245 pounds. My father's family is completely dead due to the diabetic complications of his family. I'm on Atkins, and I'll probably be on Atkins till I die. But it's the only way to maintain my weight and my health. But whatever it is, it's a lack of relevance on the most basic personal levels that keep patients from losing weight, from accepting diets from the docs. The disparity is an inability to mold the medical care and the education to the true needs of the patient. Whether it be language, social structures, family structures and dynamics, priorities and finances, we're unable to mold the medical care to that patient. If I have a 70-year-old man who has to be bed rest, but his wife is in critical care at the hospital, he's going to accept my information, but he's not going to follow through with it. I need to understand what their needs and wants are. People will not mold themselves to expectations of the healthcare professionals without receiving an understanding of the patient's priorities, an acceptance of that patient, a respect and a relevance to the patient's environment, and a little bit of negotiation. How we deal with it in our practice is an involvement of family, friends, and community. We keep the newest medications, and we also keep the oldest, and we deal with the economics. Medi-Cal recently stopped foot services for podiatrists. We see our patients for free. We allow them to come in and receive the treatment. No one will receive an amputation based on economics in our practice. We identify the real needs of the patient and family, and we mold the encounter to that patient, and we make it easy for the patient to accept the treatment recommendations and the education and to just say, yes, I'll follow your instructions. Of course, we don't believe them until someone in the family says they're really doing it. Advocacy is the protection of the rights of the patient in choosing their treatment and alternatives. Education to the patient and the family, both with relevance, respect, and a willingness to negotiate, and an education of the patient's primary care doctors. We also fight a lot, and we fight the doctors wanting to amputate as the primary treatment. We embrace the diversity of all of our communities. Our education, especially with the Latino Diabetes Association, of which I'm a board member, includes the education that's ethnic specific, language specific, dietary specific, and social structure specific, because all of our structures are a little bit different. We have hands-on teaching, safe, neutral settings, not medical centers. We keep on churches, schools, community centers, and we have a respect for our communities. The Latino Diabetes Association allows us 30 talks per year just for wound care. Now they have many more concerning diet, cooking, medication, diabetic controls, and whatever. They have multiple screenings, and they are relevant. They're relevant to the community, and that's their success. So for the problem is, for all the advances we've achieved in saving extremities, amputations are still being offered as a primary and often the only treatment, mostly due to lack of training and ignorance. Dr. Peter Sheehan, who's an extremely well-known wound specialist in New York, stated in 2006 that there are no more no-option patients. There's always an option. Before any amputation, there should be some type of intervention. Dr. Sheehan wasn't there when Ethelyn Adams came to my office. Ethelyn Adams was a teacher at LA Unified. She was a star. Her students in South Central went to college more often than not, and she was one of the most wonderful people that you could ever want. She had an amputation of her left extremity at UCLA. about a year and a half prior to coming to our practice. She came to our practice with gangrene on the right foot. She was told that she needed to schedule the amputation of the right leg sometime in the next few weeks. I promised her that we would heal the wound no matter what it took. Now, normally, most wounds heal within 6 to 12 weeks. Hers took 10 months, and we healed it. And as you can see, the photo on the right was the healing, completely healed toe, not needing the amputation. Unfortunately, well, fortunately, she healed, and she wanted to put her foot in the Pacific. She went to Hawaii. I mentioned that that Pacific is also in Santa Monica, but she wanted to go to Hawaii. So she went to Hawaii after healing. And while she was in Hawaii, she suffered a fatal heart attack and died. She died 2 years to the date of receiving the amputation on the left extremity. It wasn't the right foot at all. She was one of the statistics of the 2-year 60% mortality rate. So I'm here today to talk for Ethlyn Adams. I'm here today to talk about the millions of patients not every year, but over the time, that have received unnecessary amputations, and the people who are dying from heart attack and stroke that really have peripheral arterial disease not being diagnosed and not being treated. Thank you.
Thank you very, very much. Wow, thank you. I'm going to ask Juan Arambula to introduce our next presenter, but before I do that, I want to introduce the chair of the Higher Education Committee, Anthony Portantino, who was here with us to say a few words. Anthony?
Thank you, Mr. Cotto. What a fascinating discussion and presentation. I want to compliment you and for bringing this together and inviting me to be a part of it. Certainly, as chair of higher ed, I see the link between education and being healthy. And I always say we should make sure that each and every California child has the ability to go into the world educated and healthy, regardless of where they come from or where they live. And it's just a moral imperative that we do that. Most of you know that I've done some work into umbilical cord blood banking, and one of the things that drives me is if we look at the inventory of stem cells that are available to treat issues like leukemia, and we see that it is not sufficient to meet the demands, the healthcare demands of our diverse population. And certainly if we bank more stem cells from ethnically diverse areas, we can treat and cure patients, again, regardless of where they come from or where they live, and it's just a moral imperative. So thank you for letting me be a part of it, and it's just fascinating. Thank you.
Thank you. Thank you very much, Chairman Portantino. Talk about impeccable timing. We have just been joined by the chairman of the Powerful Appropriations Committee, Assembly Member Kevin De Leon, who will introduce our next presenter.
Thank you very much from the venerable chair of the Government Organizational Committee, as well as the chairman emeritus of the Latino Legislative Caucus. It is my pleasure to introduce Dr. Bill Relaford. Dr. Bill Relaford is with the Black Barbershop Health Outreach Program. He is a graduate of Temple School of Podiatric Medicine in Philadelphia. He began his practice in 1990 and established the Diabetic Foot Institute, a facility dedicated exclusively to the reduction of diabetes-related amputations in high-risk populations, primarily of African American and well as Latino communities. Dr. Relaford is recognized both domestically as well as internationally as a leader in the field of diabetic limb salvage wound care. Dr. Relaford is also founder and CEO of the Relaford Institute for Limb Salvage and Wound Care at the Miracle Mile Medical Center in Southern California, specifically in the city of Los Angeles. Dr. Relaford's institution's mission is to effectively decrease diabetes-related amputation rate in Los Angeles and its surrounding communities by providing a comprehensive wound care and limb salvage service. Dr. Relaford Institute, the Relaford Institute also addresses patients' specialized needs and creates individual treatment plans to heal wounds and prevent amputation. As we know, I'm sure that this has been broached upon throughout the day, but we know that diabetes is on the rise, particularly in communities of color throughout the country, particularly those who are socioeconomically disadvantaged in comparison to other communities. Diabetes has a very negative impact, as we know, on people of color, Latinos, and African Americans. So I thank Dr. Relaford for his expertise and his passion and what he does. So let's give a welcome to Dr. Relaford.
Here we go.
Good afternoon, Honorable Chairperson, legislators, and our distinguished panel. Thank you for giving me the opportunity to share with you something that's very passionate to me, and that is addressing healthcare disparities in African American men in particular. As my introduction stated, I founded what's called the Black Barbershop Health Outreach Program back in 2007 in December. Now more than ever, we need to begin to explore innovative and creative ways to deliver healthcare messages. And we found that the barbershop, as far as African American men are concerned, was the perfect place. Some of the things you're going to see in a moment are perhaps a little graphic. It's going to be a brief departure from what you typically see in a presentation like this. You're going to actually hear from men in the barbershop. You're going to hear a few people that have been recommended for amputation who didn't need an amputation. So it's my pleasure to be here this afternoon. Let me make sure my computer's working here. We'll keep going. The Black Barbershop Health Outreach Program began out of the need to find an innovative way to address what I believe the most underserved and disenfranchised group in this country. And we believe that's African American men. When you look at the fact that African American men can expect to receive better health care in prison than on the streets, when you look at the health care expenditures for a prisoner, which is approximately $6.75 a day, versus our civilians of $4.50 a day. That $2 differential, if it was put on the front end, could pay enormous dividends in preventing some of the things that perhaps ended up or created the reason why they're in the prison in the first place. So what I'd like to do today is to, this is going to start over, maybe I'll be lucky. Technology is good, but when it does what it wants to do, okay, here we go. So with the Black Barbershop Program, it was quite interesting to see men who've never been to the doctor before in their life. Here in this state, never been to a doctor. Many of the men were actually diagnosed for the first time with diabetes and high blood pressure in the barbershop. We had to send them straight to the emergency room from the barbershop because they had diabetes out of control. They had blood pressures of 200 and over 100, totally unaware that they were this far from the grave. Some of the recent studies have shown that African Americans are disproportionately at risk of heart attack and stroke than any other group in this society. African American men have the highest recorded blood pressure in the world in Chicago. And you wonder what has happened from the west coast of Africa to the Chicago and Los Angeles. And even when you factor in income, African American men still have lower life expectancies than white men with the same identical income. We have a problem. Someone was recommended for amputation, didn't need it. Knee amputation for this handsome young man right here. Right? And how old are you?
88 years old. In 2007.
And they wanted to amputate this leg right here.
The right leg.
You're right, the whole leg?
Below the knee.
Below the knee. Show me where they want to amputate.
Below the knee.
Below the knee. And you've been playing softball?
Practiced since high school.
Now this leg looks good to me. There was a little callus right here which we removed. Now the quality of that clip does not really give you the appreciation for the fact that this person had no lesion on his foot at all. He's active, playing baseball every day, 88 years old, but yet our system recommended amputation so casually for someone. Was it for the fact that he was African American? Who knows? He came to our clinic the day with the consent form in hand that I'm recommended for amputation today, and I thought I'd come to your clinic. He's still playing baseball today. So we have a problem. This young man was recommended for amputation partly because of his own non-compliance.
The problem is I should start gaining weight again. Sugar got a little bit out of control. Then all of a sudden I got a corn underfoot, which in turn turned into a callus, and then the callus turned into a blister.
Now, that young man was recommended for below-the-knee amputation without the benefit of being offered an angiogram, an angioplasty. Just cut it off. These are the things that are driving healthcare disparities in our community. African-American men are less likely to have access to healthcare services, less likely to be insured, the lowest life expectancy of any group in this society, and higher levels of poverty, unemployment, incarceration, as well as discrimination are factors that are sending African-American men to premature graves. When our men die prematurely, it further deteriorates the fabric of our community because there's no transfer of knowledge, there's no transfer of wealth if daddy is not in the home. So that's why we started what we call the Black Barbershop Health Outreach Program, and we go around the country and we screen men for diabetes and high blood pressure right in the barbershop. We're very proud to say that we've had the benefit, and not that we have actually sought after the media. We've been on The View, NBC Nightly News, The Today Show, as well as other great media.
Knowing that you have to move, get exercise and things like that.
This young man, for the first time, he walks into the barbershop. In his mind, he's healthy. He's doing us a favor from getting his blood pressure checked, only to find out this.
That's his blood pressure.
But it's high. It's very high.
It is a little high. And one of the things that I'm going to do, along with this book that I'm going to give you, is a blood pressure tracker, so that you can periodically check your blood pressures at some of the local forums.
What do you think about the barbershop program?
Oh, it was nice. I come to find out about my high blood sugar, and I have it a little bit, but what I really want to know is my diabetes, and I don't have it. You know, I found that out here, so.
When the last time you been to the doctor?
It's been a long while.
How long?
A long while. It's been years. I'm 49 years old, so I say I probably was in my 20s when I went to the doctor about this. So I come here and I find out everything I want to know, and I thank the Lord for that.
And where are you?
I'm at the barbershop at Tight Edge Barbershop.
This man has not been to a doctor in over 20 years. There's a problem when you have people in the most industrialized nation in the world, and today we still have individuals who have not been to a doctor in decades.
All right, thank you much, man.
So what we have found out is that the barbershop is what we call a familiar place. Black-owned barbershops. Barbershops historically have been a part of the African American community because they served as meeting places during the civil rights movement. We couldn't meet out in the open, so we either met at churches, barbershops, and beauty salons. So now the barbershop is playing an additional role to add healthcare information. The barbershop is an existing infrastructure in our community. It's always been there. So our motto with my foundation is take what's already there, utilize that for the benefit, in this case, of addressing healthcare disparities and delivering healthy messages to our community, and particularly African American men. Would you believe that what we find is that when you make the African American men healthier in the family, that helps other members of the family become healthier too. So we believe that also you need to invest in the head of the family as well. Many of our men find it very difficult to get Medicaid if they don't have children. Only in some parts around the country you can't get Medicaid unless you enter the emergency room. That's not health care. So far to date, we've screened over 10,000 men with our foundation. We've been in over 350 barbershops around the country in 13 cities. So what you'll see see as we close is just a few snapshots of what we see around the country with our barbershop program.
I think they need to do that more often. And the black barbershop that you have is a great thing. It's great. It allows black males to get checked for diabetes and high blood pressure.
I just think it was a good opportunity for me to get checked, because me, myself, I really don't take advantage of going to the doctor like I should. So thanks for y'all. Thanks for coming out here and giving us a chance to get checked out. Thank you.
We have certain recommendations from our findings. We'd like to see an expansion of health care coverage to African American men. We'd also would like to see we call strategy 2 is increased availability of community-based screenings and services, as well as outreach for cardiovascular disease. We also would like to recommend we call it strategy number 3, build a culturally competent workforce. Many African American men feel uncomfortable going to facilities where there's no cultural diversity. We also would like to recommend the decrease in racial disparities for African American men as a whole to help address the health care crisis that we have in this country. Additionally, we would also like to recommend the elimination of fail first practices of insurance companies, where you have to fail first on medications and then be given the medication that the doctor recommended. We also recommend the expansion of research and data collection on the health of African American men around the country. In addition to that, we'd like to share with you some of the things that are forthcoming, some very exciting programs. In closing, we have what's called...
I think it's very interesting that people get checked out, see if they got diabetes or high blood pressure, because what you know, I mean, what's on the inside, you know what I'm saying, you might not know on the outside. It could hurt people, you know. A lot of young people out here drinking alcohol, eating the wrong food, and that causes like sugar diabetes, and also high blood pressure, man. I think it's very interesting.
We've been to Harlem, we've been to Sacramento. Our goal for 2010 is to screen close to 20,000 men around the country. We've been to Chicago.
Like I was saying earlier, a lot of brothers came into the shop not knowing that they had high blood pressure or even diabetes. So we were able to help some of the black male African Americans in the community to know that they have this problem.
In New York, this young man almost had blood pressure 200 over 100. So as you can see, the barbershop is a place where we can get the message out to our people about adopting healthy lifestyles. We're in Vallejo, California, and the groups there here in Northern California have been very instrumental with partnering with us and helping to achieve our goal. What's next? Briefly, November the 7th, we will be in Los Angeles in over 100 black-owned barbershops. Our goal will be to screen close to 2,500 men. November 1, we will have something a little different, a black barbershop basketball tournament with all the barbershops in the city. Whoever wins the 3-on-3 will get some prizes and things like that. At that time, we'll be able to slip in a little information about eating right and exercise and things like that. Also, too, I'd like to share with you the fact that our foundation, along with a dozen others, are putting together what's called Fit to Lead report card. Our legislators, our clergy, as well as our teachers will be kind of evaluated to make sure, since that you are instrumental in the health landscape of our community, to see what kind of practices you have. So that report card and that survey will come out. You'll get a survey at the end of this year in your offices, and your individual practices may be highlighted, all the good ones, of course. And so I want to let you know that that's coming out soon. In addition to that, we have a program called First Saturdays, funded in part by a appropriation from Congresswoman Maxine Waters, where we will, for 2 years, test men in barbershops the first Saturday of every month for diabetes and high blood pressure. It has been a pleasure. Thank you so much for your time.
Thank you very, very much. Big round of applause, please. Our next, we're going to keep it moving right along. Our next presenter, our next introduction will be made by Assemblymember Mariko Yamada. But before we do that, Fiona Ma, you wanted to make a little quick introduction?
I do. Thank you, Mr. Chair, and I'd just like to indulge the committee and introduce a special guest that is up here today, Amy Smart. She is an actress best known for Butterfly Effect and Just Friends. She's also an environmental activist working for environmental causes for 15 years. She was extremely helpful on my bill to ban phthalates 2 years ago, AB 1108. Since we banned phthalates, Senator Feinstein did put it into the U.S. Consumer Product Safety Bill. It is now law across the country. We recently did a test of about a dozen toys that we purchased, and all of them are phthalate-free. So mothers, parents, grandmothers can feel safer that the baby products are phthalate-free, and she is up here today to lend her support to SB 797 to ban bisphenol A. That is a chemical used to make plastics harder in baby bottles and baby formula. So thank you for your indulgence. She's just going to make a couple comments. Thank you, Mr. Chair.
Thank you. Hi. I am so happy to be here because I really feel like the time has come to say enough is enough. From all the air we breathe, to the water we drink, to the food we eat, to the products that we give our kids, we're being so overexposed to these dangerous chemicals. And I want to say, you know, at some point I plan to be a mother, and I really never want to expose myself or my children to these chemicals. And now there are baby-free, there's bottles that are made with BPA that are BPA-free, and it's easy to make, it's easy to do, but unfortunately it's only accessible to people who have money. And this is really affecting, this chemical is greatly affecting these children on really high rates, and it's causing a lot of problems. And I would like to think that the government is protecting us, but they're not. So I am here in support of banning BPA from all baby care feeding products, and I would really appreciate your support.
Thank you.
Thank you.
Thank you very much. Thank you, Fiona Ma. Next, our next presenter will be introduced by Mariko Yamada.
Thank you, Mr. Chair and members. I'm very delighted to be able to introduce one of my colleagues in the Assembly, Assemblymember Mike Eng, who represents the 49th Assembly District located in eastern Los Angeles. And it looks like he's giving me a cue here, so you're ready, right? Oh, okay, very good. He represents the cities of Alhambra, El Monte, Monterey Park, Rosemead, San Gabriel, San Marino, and South El Monte, for those of you who are familiar with the eastern Los Angeles area. Mr. Eng is an attorney by profession, but he also earned a bachelor's and master's degree at UH, which I will applaud him for. He did go to UCLA, which I won't applaud him for because I was from the other school across town. But we are colleagues on the floor, and he currently chairs the Assembly Transportation Committee. He took initiative in the API Legislative Caucus last year to bring attention to the issue of health disparities in the Asian Pacific Islander community, went out and secured outside funding in order to do a little study, and I believe he's going to be presenting a white paper on our behalf today. So please join me in welcoming Assemblymember Mike Eng.
Thank you. It's an honor. I'm getting ready for somebody to say move the bill, but I think I'm going to instead tell you that I've been moved by the presentations today and how important this is. This hearing today on health disparities is really a matter of life and death. And let me just very briefly tell you how I got involved in this issue. First of all, I'm one of the few members of the California legislature that's actually worked in the emergency room. I worked for 3 years. I'm so old that I worked under the original Henry Kaiser. I actually knew him. And I remember in the emergency room one night, a young woman was brought in by ambulance with severe bleeding. And she was 16 years old, and she was about ready to give birth to a newborn. And before the emergency room doctor passed her over to the L&D doctor, which is the labor and delivery doctor, he asked her a question. And I can still see her eyes and hear her voice to this day, 40 years later. And this was the question: young lady, you're in pretty bad shape. You're bleeding profusely. When's the last time you had a prenatal? And the young woman looked up at him, her eyes tired from this long session of bleeding, and said, "Sir, you're the first doctor I've ever met in my life. I've never been examined by a doctor before. And here's a young woman in our society, in the richest nation." And I began immediately trying to find out why it was that that young individual had never seen a physician before. And then when I happened to, 3 years later, I graduated, got my degree, went to law school, and came up to the legislature. And I remember that I was asked to vote on a very significant health care comprehensive bill on prisons. And I asked a simple question. And the question was, how many Asian Americans are there in jail? And I was given this answer: we don't know. Most of the statistics are on Latinos and African Americans and Anglos. And I knew that was not true. I knew that was not true because I met my wife when I was in jail. And let me explain what that means. I happened to be part of a project that went out to the California Institute of Men jail in Chino. And there were dozens and dozens of Asian Americans who were there who had basically been forgotten by their communities because it was such a shame to have someone in prison. Nobody visited them. They came out, and nobody provided any support services. We fast forward, and again, I had to vote on and I did not get the answer then. And then we had to vote on very significant health care legislation. I asked, what is the state of Asian Americans right now? And I got an answer of, we don't really know. You're the model minority. There are very few studies that have studied your community. And I'd like to show you something that inspired me, and it's called The State of Black America. And what it was a compendium that I happened to read for Black History Month when I was sitting not far from here in the California Assembly chambers. And what I read was an amazing report authored by someone you may happen to know. Her name is the Honorable Karen Bass. And what it was is it took readers through a study of economic trends, housing trends, equality, health, education, and criminal, and on about the African American community. And I went to our caucus and I said, I'd like to know about one thing. What research has there been done on just one of these topics in the Asian American community? And I was told to perhaps look at health, which is my passion. I want to close by sharing with you some shocking information. I asked some very, very important people from the University of California to come up with all the research that had been done on Asian Pacific Islanders and health. And the first question I was asked was, well, what group are you talking about? Because there are 25 categories of Asian Pacific Islanders. And what we found was that 3 of them, Chinese Americans, Japanese Americans, and Korean Americans, are studied relatively in comparison to African Americans and Latinos and Anglos. But the remaining 22 groups, there is very, very little study. And so that was the first shocking thing. And the second thing we discovered was that in the Asian American community, all of the ethnic groups are aggregated into one. And so it's that Asian American. And so as a group, this group does fairly well in many categories. But as you know, if we were to aggregate breast cancer for males and females, as a human race, we're probably not doing pretty badly. But when you disaggregate the data for breast cancer, you will find that women are at risk at alarming rates. And this is what the outlook that we operate under in terms of the Asian American community, to disaggregate the data. I want to just close by telling you about what some of the findings that we have to date. And I want to thank Mr. Cotto for his foresight in telling me about how important it is for this type of research and including us in this. Thank you. Would you give Mr. Cotto, the Honorable Joe Cotto, a hand for your incredible dynamic leadership in this area, and the others that have done this as well. We found that the Asian American, Native, Hawaiian, Pacific Islander population, see, even to describe ourselves, it takes about an hour, because we are a really diverse section of the population. But we are the only racial group for whom the leading cause of death is cancer. Liver cancer disproportionately strikes at this population with higher rates than almost any other group. Asian American women have nearly double the rate of non-compliance with cervical cancer screening. Asian American men have higher rates of non-compliance with prostate cancer rate. In fact, you know, in the Asian American community, the sense of self is very important. The sense of being touched is even a culturally sensitive area. So you add that together and you ask how many Asian men want to have a prostate exam, and I'm telling you, you have a problem, Houston.
Houston or Hong Kong.
Asian Americans account for the largest proportion of tuberculosis and chronic hepatitis B cases in California, and I'd like to thank my colleague Fiona Ma for the outstanding leadership that you have provided, not just in the Asian American community, but by the linkages to the other at-risk population. And can we give Assemblywoman Fiona Ma a round of applause? Our majority whip. Also, there's an alarming rate of obesity in children. And many people look at me and say, Mike, isn't Asian Americans, aren't you at risk for anorexia? Why would it be obesity? But if you look at our population, there is tremendous risk for obesity. In particular, our Samoan children have the largest rate of body mass index than any other group in California. 46% and 70% respectively of Filipino and Native Hawaiian Pacific Islander adults are overweight or obese compared to the state average of 34%. We average anywhere from 46 to 70% in that category. 25% of adult Filipino males are current smokers, exceeding the average of 19%. Korean Americans have the highest rate of being not insured than any other ethnic group in the state of California. Vietnamese and Native Hawaiian Pacific Islanders experience frequent mental distress at higher rates than their other counterparts. So let me just segue here for a few seconds before I get the hook. Cambodian immigrants that immigrated to this country 20 years ago have anecdotally, in our first rounds of studies, a rate of post-traumatic stress syndrome from 20 years ago than returning veterans from Iraq and Afghanistan that may have just returned a few weeks ago. And why is that? Because this population witnessed mothers, brothers, children, parents tortured to death in front of them. And that's why it escaped. The data is so sparse that we don't even have a study on that. We only have anecdotal evidence. And in conclusion, what this, let's not call it a white paper, but let's call it a multicolored rainbow paper, has led us to conclude is that we need to know more about these communities. We need to determine if there are cultural factors that contribute to this. We need to determine why it is that the other 22 Asian Pacific Islander groups are not being studied. We need to have a conversation with funders and researchers to determine how we can set up priorities. And finally, we need to work together, because frankly, the very things that are determining our lifestyle, that are lessening our birth and longevity rates, are really the same. And by listening to the speakers today, we have discovered something very important, is that although we may live apart, we are probably all dying together.
Thank you.
Thank you.
Thank you very much, Assemblymember Mike Eng. The next presenters will be introduced by Fiona Ma. Please, Fiona.
Thank you, Mr. Chair. It is my honor to present Ms. Alicia Sanchez. She is a legislative advocate for the American Cancer Society. She helps advocacy efforts for increased funding to cancer research and greater access to cancer prevention and detection opportunities. Previously, she worked for the late Majority Floor Leader Marco Antonio Fireball.
Thank you. Am I on? Yes. I want to thank the caucuses for inviting us and me to participate in the presentation today. And I am usually before you as the legislative advocate and will speak briefly about some of the work we're doing there, but also was asked to talk about the programs that we have and outreach that we're doing. So I will be doing that as well. And the American Cancer Society is the nationwide community-based voluntary health organization dedicated to eliminating cancer, saving lives, diminishing suffering from cancer through research, education, advocacy, and service. And in fact, we are now the official sponsors of birthdays, which I don't know if you've seen our new campaign, but it's a fun way to address what is a very serious issue of trying to save lives through education, outreach, and advocacy. So I think I've only got a few minutes, and the work that we do is broad and very encompassing. So I look forward to talking with you at more length at the presentation or at the session afterwards. But we all agree at this point that there are health disparities, and those exist in cancer across the different communities, even as you mentioned, Assemblymember Ng, within communities, you see disparities. And so we understand that to achieve our goals, we are going to need to address those. And we are doing that in the different buckets of work that we undertake every day. And just as a couple examples, with respect to the education and outreach that we're doing, which really speaks to the importance of working across the continuum, which I want to recognize the statements that Dr. Smith made about really access to health care is not the only issue that we need to address, but really need to be addressing health disparities across the continuum. And in that outreach, we are looking at ways to incorporate culturally competent messaging to communities. For example, we've had a media campaign for the last 3 years doing outreach on colorectal cancer screening in Chinese, Korean, and Vietnamese communities, and another media campaign on colorectal cancer specific to African American communities. We have a call center that's staffed 24 hours a day that has people who can respond in multiple languages. And last year, that call center provided information to over 40,000 callers in California. We have a program called the Body and Soul Program, which is a wellness program that encourages participants to eat 5 to 9 servings of fruits and vegetables every day. That was developed specifically for the African American community and focuses on collaboration with churches to do that outreach, and is now being expanded into Latino communities as well. We have a unit specifically that focuses on outreach to the Chinese community. We also provide transportation services, and I'm getting yanked off, so I will condense my comments even further to note that, of course, we do this outreach, but we need to do advocacy because that will help us expand the individual reach we may have through these programs and amplify our success. And so we do that here at the Capitol. We'll be working on access to care, along with a lot of prevention and early detection kinds of things like tobacco control, increasing the tobacco tax, ensuring that cancer research is funded. In particular, I would like to note the California Cancer Registry, which allows us to collect data to answer these questions, which I would imagine some of the information Assemblymember Ng has been pulled from the data collected through the California Cancer Registry. And so to that end, we hope that we can both do the necessary outreach to these communities as well as expand the structural policy needs in the insurance and health delivery system to address cancer.
Thank you, Mr. Chair. Okay, the next speaker is Ms. Tanise Harris. She's a volunteer with the American Heart Association. She's an attorney by trade with a focus on civil rights law, but has a large personal and professional interest in public health, especially as it relates to raising awareness about heart disease and strokes. Welcome.
Distinguished panelists, thank you for having us here today. I am a volunteer with the American Heart Association as well as the National Stroke Association. I'm here today to tell you briefly about some of the efforts of the American Heart Association as it relates to reducing and eliminating, hopefully, health disparities in this country. But before I tell you about those disparities and some of the work that the American Heart Association is doing, I'd like to tell you why I became a volunteer for the American Heart Association and the American Stroke Association. I have had several family members, I've actually lost count at this point, that have been afflicted by heart disease and stroke and other highly preventable diseases. And because I became afraid personally that I might too be a victim of these diseases, I took it upon myself to educate myself about heart disease and stroke and attempted to, over the years, to share that information with members of my family. And I can fortunately say that I've made some progress. A number of family members have changed their lifestyles for the better. But despite that, I've lost a number of family members to heart disease and stroke. My family's circumstances is only a microcosm of a much larger problem, as you've heard here today, related to heart disease and stroke. As you all may know, heart disease is the #1 killer in this country, and stroke is the #3. Yet last year, 81,000 Californians died of heart disease and stroke. Not only is there a loss of life impact, there's also an economic impact. Last year, we spent about $450 billion to treat heart patients and stroke victims. This year, it is estimated we will spend almost even more than that, $475 billion towards those efforts. As you've heard here from our panelists, African Americans and Latinos are at greater risk of these diseases. And that should not be the case. One's race or sex or ethnicity should not be a barrier to health care and should not increase their risk for developing these diseases. More women die of cardiovascular disease than the next 5 leading causes of death combined. Cardiovascular disease accounts for more than 1/3 of disparity in potential years lost between African Americans and whites. The incidence of stroke in the Latino community is much higher than that of whites. In an effort to address some of these staggering statistics and to reduce and eliminate health care disparities, the American Heart Association, as well as the American Stroke Association, has developed a series of culturally sensitive initiatives and campaigns designed to target these at-risk populations. And just to name a few, as related to heart disease, reducing heart disease in both the Latino and African American community, there is Search Your Heart, also known as SYH, as well as Conecta Su Corazon here in the western states. Stroke education programs such as Power to End Stroke and Juntos, and these programs are both geared towards stroke, reducing the risk in the African American and Latino community. I am more than proud to say that the American Heart Association, as well as the American Stroke Association, has been very successful in achieving their goals. They set a goal in 1999 to reduce the amount or incident of stroke and heart disease in the United States, and I am glad to say that that goal was set for 2010, and we've already achieved it, a 25% reduction in 2009. The American Heart Association takes this issue of health disparities very seriously, and would like to work with you and your respective districts on these issues. Thank you.
Thank you very much.
Thank you. And our next speaker is Ms. Jackie McGrath. She is the State Policy Director for the Alzheimer's Association. In this capacity, she represents more than 588,000 Californians living with Alzheimer's and other dementia disorders and their family givers. She also serves on the Olmsted Advisory Committee and has been involved in public health advocacy for over 30 years. Thank you and welcome, Ms. McGrath.
Thank you, Ms. Ma, and thank you, Mr. Cotto, and members who are here. The Alzheimer's Association is the leading voluntary health organization in Alzheimer's care, support, and research. We are a resource for your constituents. We are a resource for the members of all of your organizations that are here in the audience. We do provide information and referral for families. Very often when someone goes to the doctor and receives a diagnosis of Alzheimer's, they're given very little information by their primary care providers. So the association is a resource as to know more about how this disease will progress, what kind of support is available. There's education for family caregivers, and we also do education for professionals as well. The association has 20 offices throughout the state, so very accessible throughout. Earlier this year, the Alzheimer's Association released the first ever California data report giving projections of what we could expect with Alzheimer's over the next 20 years. And the data was shocking. We know that we're going to see a doubling of this very tragic disease just between now and 2030. And we'll see a tripling by 2050. But to compound that in the context of today's discussion, we know that between now and 2030 there will actually be a tripling among Latinos of Alzheimer's and a tripling among the Asian and Pacific Islanders. Further on this issue of health disparities, we know that people of color are much more likely to be diagnosed later in the progression of Alzheimer's. This is largely due to the fact that there's cultural bias in cognitive testing. There's inadequate translation of diagnostic tools, and there's a lack of bilingual health professionals. The consequences of this fact are primarily two. One is that we know that there is a serious underreporting of people of color in particular who have Alzheimer's. And I applaud Mr. Ng and the white paper of his caucus to bring some focus on the lack of data. It's appalling, and it leaves us, as well as you as policymakers, really very unprepared to know how to address policy changes and health reforms. So I am hopeful that this can lead to something else. And secondly, a consequence of this later diagnosing for people of color is that they receive treatments much later in the progression of the disease. And the result of that is obvious. The treatments that we have are far likely to be effective and as effective for these populations. California has 10 Alzheimer's disease centers throughout the state. These centers are doing state-of-the-art diagnosing, not only for Caucasians, but for people of color. This has come as a result of years of research at these centers. But here lies in the problem for the disparity issues you're wanting to address, Mr. Cotto and members. These diagnostic tools are not getting out into the mainstream health community. They're not getting to the primary care physicians, which is where most people are diagnosed with Alzheimer's. With respect to models of outreach, which you wanted us to address in this part, I would say that the association has received Older Americans Act funding and has created some model programs for outreaching to Latinos and outreaching to the Asian Pacific Islander communities. and I'd be happy to talk to any of you about some of those after this, since I know they're calling time on me. I would just conclude by saying on September 21st is World Alzheimer's Day, and the association will actually be launching, in partnership with this administration, the development of a state Alzheimer's plan, which holds great promise for addressing not only the disparity issues we're talking about here today, but health care in general, looking at the total person. We know as people age, most people have multiple chronic conditions. People with Alzheimer's have 2, 3, 4 other chronic conditions, many of which you've heard about today, diabetes, heart disease. So we're very hopeful that embarking on this state plan will provide us some answers and some guidance and a policy roadmap for us to address some of these health disparity issues. Thank you.
Thank you very much. Our next presenter is Dr. Robert Robles, MD, is board certified in medical oncology. He is a senior partner at Diablo Valley Oncology, located at the California Center and Research Institute in Pleasant Hill. Dr. Robles, please.
Thank you very much for the invitation to speak. I speak as an oncologist in private practice, and so I sort of I guess it's the sharp end of the stick for cancer care. There's good news about cancer care, and that cancer death rates have been falling. The bad news is that that benefit is very unequally distributed. Looking just at breast cancer, a very recent publication has demonstrated a falling breast cancer death rate for both African American and Caucasian women. However, the improvement of Caucasian women was much greater than that in African American women, so the disparity has gotten even worse over the past several years. There's been a lot of research within the oncology community asking these questions, why? There are certainly some obvious ones. Lack of access to screening. We know that cancer is very expensive to treat, and it's much, much easier and cheaper to prevent. And so a lot of effort's been put into earlier treatment, earlier screening, earlier prevention, which is successful for a number of cancers. One of the other aspects as looked at is, are the treatments different between different racial and ethnic groups? And again, some research has just come out, and a very disturbing paper was just recently published again within our literature that looked specifically at African American men and women treated in a large national group with similar treatments, similar patients supposedly, and found very striking disparities in survival rates despite what we thought would be state-of-the-art care under ideal conditions. And this, of course, raises, well, why? Everything looks standardized. We oncologists put a lot of effort into trying to provide the best standard of care that we can, no matter who we're seeing in front of us. But another recent publication looked at, it may not necessarily be the specific treatments, but perhaps the healthcare systems, and that looking at African American men and women specifically suffer what appears to be disproportionately, or rather disproportionately excessive poor care after they're diagnosed with breast and colon cancer, where a man or woman, African American man or woman with colon cancer may have a 50% higher death rate depending on where they're treated, specifically what kind of hospital they're treated in. And these are very disturbing findings that we're realizing, and we honestly don't have much more information other than that. From a practical point of view, as someone who's in private practice and who has the privilege of working with our county health system, pretty closely, have a lot of respect for them, that from just a purely anecdotal point of view, I can tell over the past 2 years specifically, we're seeing more and more uninsured patients coming into our, it's a nonprofit health system for which we're asked to take care of. And these are disproportionately people of color, disproportionately people with very advanced cancers. We do our best to diagnose, get them started in treatment, and refer them to the public health system. But this is, I think, unfortunately, sort of a very small but telling point on the failures of our current health care system. Thank you very much for the time.
Thank you very much. Our next presenter will be introduced by our resident doctor here in the legislature, Dr. Ed Hernandez. Dr. Hernandez, please.
Thank you, Assemblymember. First of all, let me take this opportunity to thank, to my left, Senator Gil Cedillo, of course, Assemblymember Joe Cotto, Assemblymember Isidore Hall, Assemblymember Ted Lieu, and Assemblymember Sandra Sonson for bringing forth this California healthcare disparities, which obviously is extremely important in light of the healthcare debate that's going to be taking place in D.C. and, of course, the attempts that we had when I was a freshman legislator. But and this is a very, very important issue. Now, I was given the task to introduce to summing up of healthcare disparities in California, and the honor of introducing the individual, and that's Dr. David Hayes Bautista. I'm sure all of you know of his great work and his writings, but he is currently Professor of Medicine and Director of the Center for the Study of Latino Health and Culture at the David Geffen School of Medicine at UCLA. He graduated from UC Berkeley and completed his doctoral work at the University of California Medical Center in San Francisco. His research focuses on the dynamics of the processes of health of the Latino population using both quantitative data sets and qualitative observation. The Center for the Study of Latino Health and Culture combines these research interests with teaching of medical students, residents, and practicing providers to manage the care of Latino patient base effectively, efficiently, and economically, and is with great pleasure, Dr. Bautista.
Thank you very much, and I really appreciate this invitation that both the Senate and the Assembly has pulled this together. Thank you very much. Well, I know you've been hearing a lot about problems. I'd like to actually present you an opportunity, because we sometimes tend to forget that diversity in a population actually creates a lot of opportunity. So if we look at the babies born in California 2 years ago, 2007, you notice that over 50% were Latino, added African American, Asian, and Pacific Islander. In fact, over 70% of the babies born in California are what we used to call minorities. Only when it's 70%, clearly this is not a minority. And in Los Angeles, in fact, almost 2/3 of the birth alone are Latino, but again, adding in African American, Asian, Pacific Islander, American Indian, over 80% of the babies born are what we used to call minorities. In Tulare County, well, gee, 3/4 of the babies there alone are Latino, and in Imperial County, 90% of the babies born are Latino. Okay, so particularly in the Latino and the Asian Pacific Islander population, we have a rather unique family situation because the moms who are giving birth tend to be immigrants. But the babies are being born here, the U.S. citizens. In fact, that's what's driving the growth of diversity in the state. It's no longer immigration, it's the births of the babies of these immigrants. So here's what this means for health. The babies that are born here, particularly immigrant parents, tend to culturally assimilate. Unfortunately, that is not good for their health. Their parents actually have some very strong health behaviors. Let me just take a look, just some data. We're doing some work on teen pregnancies. Now, what you notice here is if we look at non-Hispanic white moms over here, 6.2% of them smoke while they were pregnant compared to 0.7% of Latinos. That is, non-Hispanic white moms are almost 10 times as likely to smoke compared to our Latina moms. But if we disaggregate those Latina moms into the U.S. born and the immigrant, well, the U.S. born are 5 times more likely to smoke compared to the immigrant mom. Interesting. Or if we just look at women in general, Latinas in general, the U.S. born are about 3 times as likely to smoke as the immigrant moms. In fact, here's we can actually look at this by language. These are data from the California Health Interview Survey. The group least likely to smoke, 4% of the women that speak only Spanish smoke. If they learn English, it doesn't harm them too much. It goes up to about 6%. It goes up a little bit. But if they don't speak Spanish, they are 3 to 4 times more likely to smoke. And of course, we know tobacco is the only product on the market that you can buy legally that, when used as directed, will kill you. Well, we can point out here that, in terms of culture and behavior, not speaking Spanish, which will lead to higher rates of smoking, in fact, will kill you. There's something about not speaking Spanish. Okay. Sexually transmitted.
Solamente hablar español es mejor.
Well, I'm just picking, by the way, you'll see the same thing with Japanese, American, Chinese. You get a similar thing. Sexually transmitted diseases, again, going back to teen moms, non-Hispanic white moms are about twice as likely to have a sexually transmitted disease when they give birth. But when we disaggregate the U.S.-born and immigrant Latina moms, well, the U.S.-born are twice as likely as immigrant to have a sexually transmitted disease when they give birth. Drug use, we'll see the same pattern. That non-Hispanic white moms who give birth are about twice as likely as Latina moms to have used drugs while they were pregnant. But when we disaggregate drug use by nativity, whether it's male or female, U.S.-born men and women are far more likely to use drugs compared to immigrant men and women. Or again, if we look at this by language, what languages speak, both men and women, Latinos who don't speak Spanish, who only speak English, have the highest rate of drug use. Whereas the immigrants, those who speak only Spanish, they tend to be immigrants, have the lowest rate. And the ones who are bilingual have a little bit higher rates, but it's nowhere near the ones that do not speak Spanish. And as we look at outcomes in terms of infant mortality, well, U.S.-born Latinas actually have higher infant mortality than immigrant, even though immigrants have lower income, lower education, get less bilingual care. But they smoke less, they drink less, they do drugs less, they have fewer sexually transmitted diseases. Now, here's what this all means. All these babies are being born. That would be approximately close to 350 to 400,000, what we used to call minority babies, largely with immigrant parents. They're going to grow up. Okay. So here's a cross-section of the Latino population by age group in Los Angeles County, start with 0 to 4 and all the way up to 90 plus. And the orange columns are that proportion of that age group that is U.S. born, and the yellow is the immigrant. So out here, with these are the parents, the 8th wave of immigration. This is not the first time that we've had immigration from Mexico here to California. These are the parents. And here are their children. You notice that when you look at children 15 and younger, Latino kids, the vast over 90% are U.S. born. Okay, so as things move forward, the Latino population is going to get progressively more U.S. born. So here's the Latino population in 2000, 2010, 2020, 2030, and becomes increasingly U.S. born again. And we've seen this before. But what will this mean in terms of behavior? Well, clearly these kids are the future of California. When they grow up, they'll be the California population. But what kind of health will they have? Well, let's just take a look at that second generation and some diabetes-related behaviors. For example, U.S.-born male, Latino males, are more likely to be obese compared to immigrant males. Now, interestingly, immigrant males are more likely to be overweight, but overweight is not as bad as obese, but you have to be overweight first before you become obese as you kind of move through that. At least that's the way I tend to do it. So it's like the immigrant males are getting ready to move in there, but the U.S.-born males are obese, and of course that has all kinds of risk factors. Well, how do they get that way? Well, it turns out the U.S.-born Latino males are more likely than immigrant Latino males to be eating fast food 3 or more times per week. That's not a good behavior. They're more likely not to have walked in the past week compared to immigrants. The immigrants are more likely to walk. Less likely to eat fresh fruits, fresh veggies. Yeah. Okay, so you kind of get the idea. So here, all these U.S.-born kids, right now they're in their adolescent, young adult years. They're growing up, but I guess one of the questions is, well, can we get enough cultural competency into our system that we can figure out what messages were the immigrant parents trying to give these kids, and can we facilitate this younger generation receiving the messages from their immigrant parents? Because if we can do that, we will avoid a whole host, obesity, smoking, drinking, drug use. But if we don't, then, okay, then we'll have all the problems. But I think we have a real tremendous opportunity here to figure out what richness, what wealth does diversity bring to a state. We have to capture it, we have to harness it, and that takes some research. Okay. Now, one of the problems is that immigrants, unfortunately, are less likely or more likely not to have health insurance. We've known this before. Or more likely not to have seen a doctor in the past year or more. So we have some things to work on. I just want to close on this because it's something over which, in fact, you all do have control. We've been looking at minority medical enrollments in the 5 University of California medical schools from 1992 up until recently. And I only have time to look at Latino. We see the exact same curves also for African American, American Indian. Okay, from 1992, and we kind of picked that because that was a good year for enrollment of underrepresented minority students in the 5 UC medical schools. Since 1992 to 2006, the Latino population grew by 55%. Now, I'm sure you've heard of the old saying that the rising tide lifts all boats. So you think, okay, there should be 55% more Latino medical students. But then some could say, well, not anybody can go to medical school. You at least have to have a college degree. So let me show you actually some good news. The number of Latinos with a bachelor's degree in that same period grew by 150%. So we're thinking, wow, we should be having Latino medical students just all over. What happened to the actual number of Latino medical students? It dropped. We are educating fewer now than we were in 1992. And we see exactly the same curve for African American enrollments and even worse curve for American Indian. So how is it these populations are growing? We're not getting into the University of California medical schools? Well, I don't know why, but we're undertaking research. I mean, I keep hearing, well, they all went out of state. Well, I happen to work with AAMC. I don't see a whole tidal wave of underrepresented minority students going out of state. Or I hear, oh, they don't get MBAs. It's quicker and easier, make more money. I do a lot of work with the schools of business. I don't see a tidal wave of URMs going into the schools of business. We're going to solve this one. We're going to figure it out. But we have to put our heads to this because these are the folks likely to do the research to figure out how do we pass along the healthy messages from immigrant parents to the Europe-born kids. So let me just finish on one illustration. We're used to thinking of the top 10 causes of death, heart, cancer, stroke, etc. But you know what? Here are the real top 10 causes of death. Tobacco use, poor diet, inactivity, alcohol consumption. Actually, you do get microbial agents like swine flu, toxics, pollutants in the air, motor vehicle accidents, firearms, sexual behavior, drugs. These are the causes of death. Oh, they're only listed as contributory on the death certificate. You know what? If they weren't driving cars at 80 miles an hour without seatbelts, you wouldn't have that death certificate. These are behavioral. These are influenced by culture. And this is the opportunity we have to really utilize the tremendous wealth that diversity has brought to the state to make this state healthier. Thank you very much.
Thank you very much, Dr. David Hayes Bautista. Before we ask Senator Cedillo for some concluding remarks and then guide us to our next step. By the way, weren't the panelists tremendous? Excellent presentation. Thank you very, very much. Before we call on Senator Cedillo, we've been joined by a longtime member of County Board of Supervisors in Santa Clara County, now an assembly member who devoted a full lifetime to the whole area of health care. Just to make some brief remarks, Assemblymember Jim Bell.
Just briefly, as a supervisor in Santa Clara County, I chaired the Santa Clara Family Health Plan, which is our Medi-Cal, managed care, S-CHIP, and we created for the first time in California the Healthy Kids program, which is to cover all kids. And we're now at, in Santa Clara County, close to 97% of all kids in the county have health coverage. And one thing when we created this entity, this managed care entity in the mid-90s, was that we discovered that these health disparities are a real issue we needed to address. So what we did is we hired a director position of cultural competence. And that person's job was to explore all the disparities in health care, find out what kind of actions we could take as a health plan to address the various disparities and to continue to address those disparities as we complete the mission of coverage for all children and all Medi-Cal, all persons in the Medi-Cal system. So I believe, and I have seen the results. The results are that health care can improve if you address the disparities, if you address the cultural issues, and have cultural competence as part of your success in your health program. So I believe that we should have this as integral to any health care reform. Any health care program should have this issue addressed. And I appreciate the Tri-Caucus for raising this issue. Thank you so much for doing it, Senator and Assembly members.
Thank you.
Well, I know all of you have a lot of questions and look forward to having some dialogue, but we're not going to do that here because we'll be here all night. We're going to go over to room 211 and we'll have a reception, and this will provide an opportunity for all the presenters to have unlimited time without anybody putting up a 60-second, 2-minute placard in front of them, and you can ask all your questions and have all your engagements there. Thank all the panelists Thank you for working within our time constraints, and thank you for your leadership on these issues. We look forward to seeing you at the reception.